Good morning, everyone. So I'm Patricia Guerrero from Florida Heart Group. I'm also the Director of Women and Heart Disease for the Florida Hospital Cardiovascular Institute. It is my great pleasure to introduce to all of you Dr. Susan Dent. Dr. Dent is a medical oncologist at the Ottawa Hospital Cancer Center. She is a professor in the Department of Medicine at the University of Ottawa. She obtained her medical degree at McMaster University and completed her postgraduate training in internal medicine at the University of Ottawa. She continued then her training in medical oncology in Ottawa, followed by a fellowship year in clinical research with the National Cancer Institute of Canada Clinical Trials Group. Presently, she is a member of the Cancer Ontario Breast Disease Site Group Practice Guidelines Committee, IND Working Group for the Breast Cancer Disease Site Committee at the National Cancer Institute for Canada Clinical Trials Group, and Grant Review Panel member for the Canadian Institute of Health Research. Her areas of interest include breast cancer, treatment toxicities, and cardiotoxicity. She is the founder of the Ottawa Cardiac Oncology Program, as well as the Canadian Cardiac Oncology Network, organizations that are dedicated to improving our understanding of how cancer treatments impact cardiovascular health with the ultimate goal of preventing cardiotoxicity. Outside, as you checked in, there were several documents for your perusal. One is a list of 3 recent papers. Dr. Dent is co-author on 2 of those papers, the most recent of which were the brand new American Heart Association and American College of Cardiology guidelines on breast cancer and cardiac toxicity. Dr. Dent travels throughout the world giving lectures on the topic of cardiotoxicity. How do we establish multidisciplinary efforts to better take care of our whole patient? So without further ado, Dr. Dent.
Thank you. So thank you very much for inviting me. I'm always anxious to be invited to places where it's warm. So it's great to actually get some sunshine and warmth and be able to walk outside. We still have snow in Ottawa. It is starting to warm up, but it's not quite there yet. So this is really nice and warm. So over the next 45 to 50 minutes or so, I'm going to talk about my perception of cancer and cardiovascular disease and how our cancer treatment impacts cardiovascular health, and how can we work together to try and improve not only the cancer care we deliver, but doing so in a means by where we don't have a negative impact on cardiovascular health. So these are my disclosures. I should have also put up there, I'm not a cardiologist, but as you heard, I'm an oncologist. So some of what you hear today will be my viewpoint on this whole new area. So the objectives I was given to cover over the next 45 minutes or so are to discuss heart disease in the patient with cancer, to discuss cardiotoxicity of established and emerging cancer drugs and practical management, and I will do this at a very high level given the time I have. And I really do want to spend some time discussing the establishment of a multidisciplinary cardio-oncology service, because I think that's what is important and a starting point, particularly at this hospital. I understand you're just starting this, so maybe I can give you some pearls as to what we did and how to move that forward. So why is it important to discuss cancer and cardiovascular health? Well, cancer and cardiovascular disease in North America, and these are Canadian statistics, represent the number 1 and 2 causes of morbidity and mortality, as you see by those 2 big pieces of the pie. And what's clear is that from at least a cancer perspective, cancer is not going away. And this is the estimated or predicted number of global cancer cases worldwide. And you can see by 2035, upwards of 25 million. So this is a problem, although we have newer therapies coming out, that we're going to be dealing with in the future. The encouraging thing, however, is if you look at the number of drugs in development for oncology, and this is a few years old now, that there are a huge number of drugs in development, far surpasses any other sort of disease site that we treat. And is this making a difference? I would say that we have indirect evidence it is. So here are the estimated number of cancer survivors in the US, and you can see by 2020 there'll be close to 18 to 20 million cancer survivors in the US alone. And so as we cure these people from their cancer, the question then becomes, what kind of life are these people left with after their treatment? And I think this is a very provocative quote, that the cured cancer patient of today does not want to become the heart failure patient of tomorrow. Now, if you speak to oncologists, they'll say, well, I never cause any cardiovascular problems. I give them their cancer treatment, I cure them, and then they go away. The problem is we discharge these people from our clinic, and we don't see them or hear about them. And 15 years later, when they're admitted to your hospital and they're in heart failure, the oncologists don't know about that. So one of the problems is that we often don't hear about the long-term consequences of our treatment, or at least not till now. So when we look at, cardiovascular disease and cancer survivors, the greatest deal of information that we have is from the pediatric population. So there is a childhood cancer survivorship study that is ongoing in the U.S., and what it clearly shows is that after the recurrence of cancer, cardiovascular disease, morbidity, and mortality is the second issue that these pediatric cancer survivors face. So 15 to 20 years out from receiving their anthracycline chemotherapy and or radiation, they have a very high risk of experiencing a cardiovascular event. Similarly, we know from studies, and there was one published in New England Journal a few years ago, the impact of radiation, particularly if the heart is in the radiation field, that for every gray of radiation that you increase, that the heart is in the field, there's a higher risk of a cardiovascular event. And what about, this is an example of women who've had breast cancer. What happens to them years out from their therapy? So this is a study actually looking at exercise capacity in women who were 3 years out from their treatment, their breast cancer treatment. And what's interesting to note, highlighted in red, is that their exercise capacity, or their VO2, at 3 years is equivalent to a 50-year-old is equivalent to a sedentary 7-year-old in terms of their exercise capacity. So there are long-lasting effects of therapy that we deliver to these women. And now there's emerging evidence that even mortality, once women survive 5 to 7 years from their breast cancer, cardiovascular mortality becomes more of a concern than recurrence of the breast cancer itself. So clearly, I think this is a very good picture of what we're dealing with, that not only as oncologists we have to worry about breast cancer recurrence, but we also have to worry about risk of cardiovascular disease and its impact on mortality. So there are many cardiovascular side effects of cancer therapy. I think as oncologists, traditionally, we have thought this is the only one because we give anthracyclines and we know they're associated with heart failure. But the cancer therapies that we give today can cause any of these or a combination of these. So thromboembolic disease, hypertension, arrhythmias, QTc prolongation, as well as acute ischemic events. By far, if we look at the traditional chemotherapy drugs that we have given, anthracyclines are the most common, and they're still used in breast cancer, in lymphomas, in leukemia. So it's still a very common chemotherapy drug. And we know that if we give a certain amount of this drug, it can definitely lead to heart failure, and that can be permanent, although there's now emerging evidence that if we treat it early, we can reverse some of that. And we've known for many years that there's a limit, a lifetime limit of the amount that you can give. And if you go beyond that, the risk of heart failure increases exponentially. There's also these drugs, 5-FU, and given orally as capecitabine, commonly used in colorectal cancer and still in breast cancer. These drugs can cause coronary spasm and ischemia. And some of the protocols for colorectal cancer now require infusional 5-FU, so they go home on a pump. And it's amazing what can happen in terms of the coronary vasospasm. It usually occurs early on when they're on the pump. But even in our own emergency department, we've had people come in with on the pumps, having chest pain, and they send them over as an acute STEMI thinking they're having an MI, but they forget to turn off the pump, or they don't know what the pump is. And so they're in the cath lab, and they're getting cath, and they still have this pump running, a 5-FU. So there's a big learning curve still around this drug. Usually, once you take away the 5-FU, the symptoms are reversible. And this is really small, just to sort of tell you there are mechanisms of anthracycline toxicity. You can certainly, it's thought to affect TOPO1 and TOPO2 and DNA damage, and this is what leads to the irreversible myocyte cell death. And with the 5-FU drugs, it affects thymidate synthase, and that leads to the ischemia. So we've known about that for a long time. And when I talked a bit about the frequency of cardiotoxicity, as I alluded to earlier, it's dose dependent. So, and it's a lifetime dose. This becomes an issue, for instance, if you have a patient with Hodgkin's disease who has anthracyclines, and then they develop breast cancer and they come back to see you, they've already had a lifetime limit, so you can't go back to that drug. And what about prognosis? If you do develop chemotherapy-induced heart failure, this is an older diagram, and with modern drugs, the prognosis is probably better, but overall it's not good. So compared to idiopathic cardiomyopathy or HIV-induced cardiomyopathy, cardiomyopathy from anthracyclines has a fairly poor prognosis. But the landscape is changing. So in oncology, we're trying to move away from the traditional chemotherapy drugs. And in this, what I would call now a simplified diagram of all the particular potential pathways that cancers have of growing, you can see there are many, many pathways where if they're amplified in different tumors, this can lead to cell cycle progression. And so the bulk of activity over the last decade has been around trying to find an antibody or a protein against these particular pathways, to block these pathways to prevent cell cycle progression. And so one of the more common ones that we've heard about, this is the EGFR family, or the epidermal growth factor family. There are antibodies against this now called pertuzumab and trastuzumab, is HER2, and vascular endothelial growth factor family, and these are anti-angiogenesis type drugs. And so more and more every day there are drugs coming out, and they themselves have an impact on cardiovascular health as well. This is actually was published in the New England Journal of Medicine just a few years ago, but to simply say that we have these sort of extracellular, these cell proteins, and there's antibodies against these, such as I alluded to, trastuzumab and pertuzumab. And on the inside of the cell, you also have small molecules called tyrosine kinase inhibitors that can also prevent these proteins from binding together and causing cell cycle progression. So there's a lot of different pathways that are being developed. So trastuzumab, commonly used in breast cancer, also used in HER2-positive gastric cancers now. It can cause cardiac dysfunction. What it normally does is it leads to a drop in the left ventricular ejection fraction. Unlike anthracyclines, this tends to be reversible if the drug is held or stopped. It's felt to be more a stunning of the heart, not actually promoting myocyte cell death. So usually, now we've learned, it's been on the market for 10 years, we've learned we can usually manage this. There are angiogenesis inhibitors as well, so such as bevacizumab, sunitinib, sorafenib, used in GI and GU malignancies. These particular drugs can lead to hypertension, and quite significant hypertension, particularly if your patient has underlying hypertension to begin with. So this is just a few studies looking at grade 3, 4 hypertension rates with these VEGF inhibitors, and you can see it can be quite significant. So already you can see, as an oncologist now, we're having these targeted therapies, but we're also running into what I call off-target side effects, causing us difficulty, particularly if they come into my practice and they already are on 1 or 2 antihypertensives. Then how do I manage these patients if I want to give them these compounds? There are other compounds out there that are multi-targeted tyrosine kinase inhibitors, used more in hematological malignancies such as CML, that can cause vascular and events. They can cause clotting, pulmonary hypertension, peripheral vascular events, and so on. And I think here I have one just to give you an example. These are some of the events for CML patients on these TKI inhibitors: peripheral vascular disease, coronary artery disease, and CVAs. So all of this sort of comes into play, particularly when you realize that we are treating and giving these drugs to patients who could be older and already have underlying cardiovascular risk factors. And this is, you can look this up, this New England Journal article from 2016, because I realize this is hard to read, but just to remind us, there's a whole host of newer therapies coming down. So every week it seems like there's a newer therapy coming down, all of them which can have potentially cardiovascular toxicity. But the new kid on the block is immunotherapy. So many of you have probably heard about the promises and the great promises of immunotherapy. And essentially what this has done is it has allowed us to unleash the immune system to try and attack cancer cells. So you see there on the left-hand side, you have the T cell with the PD-1, which is a protein on the surface, binds to PD-L1 on the tumor cell, and that binding prevents the T cell from attacking and killing the cancer cell. Now we've developed antibodies called anti-PD-1 or anti-PD-L1 that block those receptors, thus allowing the T cell to recognize and to kill the tumor cell. So that has led to a whole host of research and a number of different compounds that have been developed. And these are, in fact, the ones that have been approved already by the FDA in mainly melanoma and non-small cell lung cancer. There's also some that have been approved in Hodgkin's lymphoma and head and neck cancer, but the big ones have been in melanoma and lung cancer. And in fact, now what they're doing is in studies, they're combining these. So they're giving more than one a checkpoint inhibitor, they're giving them in combination. The problem is that, of course, this is great and it's made great headway in terms of particularly melanoma, but they can cause toxicity. And also what happens is these checkpoint inhibitors can attack other parts of the body. So I call it the itis effect. So thyroiditis, different immuno impacts. They can take out the adrenal glands. They come in with a colitis, many different effects. So these patients can be quite sick. But they can also cause cardiovascular toxicity. So this was an article published in the New England Journal 2016 looking at fulminant myocarditis with immune checkpoint blockade. In fact, this was a patient with melanoma that had a combination of 2 different checkpoint inhibitors. And since that time, there have been a case series of myocarditis reported with these compounds. Now, it's not particularly common, it's still rare, but I think it was a real wake-up call that, you know, these drugs are good drugs, but they can have catastrophic events. So it was important that at least we're now aware of this and now trying to figure out how to deal with it. So that's all I'm going to say about chemotherapy drugs and novel therapies. Let's look at a case of a 65-year-old woman with node-positive breast cancer that's estrogen and progesterone receptor positive, and she carries the HER2 protein. Her oncologist recommends anthracycline-based chemotherapy and trastuzumab. She has a history of hypertension and diabetes. She has a 30-pack smoking history. Physical exam and baseline blood work are normal, and the oncologist orders a baseline echocardiogram. Now, in our center, some would argue they don't have to, some would, but this oncologist did. And this is what the echo shows. So fortunately, in our center, we do have echo with strain. This was the LVF, it was 40%. Global longitudinal strain was minus 15%, so clearly abnormal, and mildly dilated LV. So then the question becomes, is how do I treat this patient? So I want to offer her life-saving therapy, but she's already at a point where her baseline LVEF is 40%. In the past, I think the answer would have been, well, I just can't treat her. But that's not clearly an answer that, as an oncologist, we want to hear. What we should know as oncologists, and I think even as cardiologists, is that there are a lot of shared risk factors between oncology patients and cardiology patients. So smoking, obesity, high BMIs, physical activity, not only are risk factors for cardiovascular disease, but they're risk factors for cancer as well. So if you take a patient with cancer and they have these underlying risk factors, you then subject them to surgery and perhaps chemotherapy and perhaps radiation and targeted therapy, then it's no wonder we sometimes unmask cardiovascular disease that may have been silent up until that point. And of course, we're also going to get patients that have both of these things at the same time. So it's learning how to deal with both of those factors. And in fact, also as oncologists, we should realize that many of the patients we're treating are older, and they have already underlying hypertension, maybe diabetes, coronary artery disease. And it's becoming more of an issue, of course, as our population ages and we're treating older and older cancer patients. So in order to provide the best cancer care, we need to really work closely with our cardiology team, I think, to try and optimize cardiac health. So going back and forth. So this is really was the impetus for us setting up a clinical program in our center in 2008. And it started out with myself, now 4 cardiologists that rotated through the clinic. We then had another medical oncologist join, a pharmacist, a research assistant, and also a fellow. So we started to introduce a whole idea of training and a cardio-oncology fellowship program. And since we started our clinic in 2008, this is just a map of North America and a few sites this side, but there has been a huge number of cardio-oncology clinics established around the world. Beyond North America, Switzerland, Brazil, England, Italy, Israel, Poland, India, and now China is coming on board in a big way as well. So the question I get asked, though, sometimes is, why do you need a clinic? What does a clinic have to offer? And I think first and foremost, it's about clinical care. So you want rapid access to cardiologists with an understanding of systemic and targeted therapies. Prior to our clinic, we would refer a cancer patient to a cardiologist, and they would say, okay, yes, I can see them in 2 months, but you need to make decisions about cancer therapy today. Or they would see them and they'd say, well, I can't even pronounce trastuzumab, whatever that is, just stop it and the patient will be fine, but you don't want to stop it, I want to keep going. So when we started our clinic, there was a huge learning curve for the cardiologists. We would meet almost weekly, actually, to go over what these drugs were, explain to them the prognosis of the patients, the importance of these drugs. So it's not just about seeing a cardiologist, it's about seeing them fairly quickly and having someone who understands the importance of these drugs and what they are. Also, I think a clinic is an opportunity for education of both patients and the healthcare providers. It's an opportunity to look at training for our residents and our fellows. It's an opportunity to have multidisciplinary rounds and discuss cases. And in fact, we do that once a month. And underpinning all of that, I think it's a platform for the development of collaborative research, all the way from basic and translational research out to clinical and health outcomes research. It's also, I think, an opportunity for shared decision-making, and it is all about that shared decision-making. So this is a diagram, actually, that one of my fellows put together. But for instance, if you have a patient who has a high cardiovascular risk, but a low potential benefit from cancer therapy, then I think that's straightforward. You need to treat their cardiovascular disease. On the other hand, if you have someone with a low cardiovascular risk, but high benefit from their cancer treatment, then proceed. It's that middle group. It's that group where they might have a moderate risk of cardiovascular disease, moderate benefit from chemo. Where do they go? And it's that conversation that needs to take place, and I think that is the group of people for a cardio-oncology assessment. What are the components of a cardio-oncology program? And I kind of alluded that to when I talked about the clinic. So clinical, obviously patient care is first and foremost, and I put members of your team, medical and radiation oncologists, hematologists, cardiologists, pharmacists, nursing, and you can keep adding to that. The education piece, which I did mention, I would stress the multidisciplinary rounds and the case rounds that we have once every month has been a real learning curve for us. Research. And then the fourth piece that we've recently added is cardio-oncology survivorship, and I'll just show you that in the next diagram. So this is sort of our program since 2008, and depending on how you want to run it in your center, we have half-day clinics each week. We get referrals from hematology, oncology, surgery. We're starting to now see referrals preoperatively from the thoracic group because of the higher risk population. And so we get them as sort of, can you see these patients pre-op? Can you see them because they're getting into trouble during their therapy? And then we see them as they're finishing or just after their therapy when they're having cardiovascular issues. So quite a range. And in 2016, we recognized, well, what happens to these patients once they've finished their cancer therapy? They're discharged from the cancer center. Where do they go, and how do we take care of them? So that's when we established a cardio-oncology survivorship clinic. So we have a cardiologist in the community. She comes to our rounds as well, and she takes we graduate the patients to that clinic, and then she follows them throughout the rest of the time. And she also, importantly, works with the primary care providers in trying to educate them as well as how to take care of these people. Because as we know, a lot of patients, it may not be the first year or two that they get into trouble. It's 5 to 10 years down the road when they're in trouble from the consequences of their therapy. So what kind of patient do we see in our clinic? This is sort of our 7 years experience out to 2015, about 780 patients. And not surprisingly, the majority of patients that we have seen have been breast cancer. The clinic really was established and driven originally by breast cancer patients on trastuzumab and drops in their LVEF. But since that time, we've seen GI and GU patients, hematological patients, and I think the reasons for referral are really driven by the cancer therapy that they receive. So, when we see tyrosine kinase inhibitors, then we see more hypertension, so that's a reason. In some of the older, in GI, sometimes it's coronary artery disease, pre-assessment, and so it's a spattering of things. But it's interesting sort of just to see what type of patients you see and why they're being referred. And then when we looked even more specifically at the breast cancer population, again, these are ones, the majority of which are being referred for asymptomatic drops in LVEF, or even, below 50 sometimes. What we found is that by referring them to our clinic and by holding the drug some time or adding in some medication, the good news is even those with moderate LV dysfunction could complete their cancer therapy. So I think it's all about not just establishing this kind of a clinic or program, but then looking at what is actually happening to the patients that are referred to the program. So education, I think it's very important to have multidisciplinary rounds and CME presentations to allied healthcare providers to let them understand why you're doing this and what it's all about. We have a fellowship program. There are a number of cardio-oncology meetings that take place across the country and now worldwide, special education sessions. The ACC now has a special section on cardio-oncology and just had a workshop. I attended the first workshop in Washington, but just had another workshop in Washington this past February. So there's a growing amount of opportunity to become involved in this, and there's also educational opportunities. We actually felt it was important to share our knowledge, so in 2011, I established the Canadian Cardiac Oncology Network with the goal really to try and bring together people from across the country. And then in 2013, we established a website where we share that. In fact, all the conferences that we support, we upload all the presentations on this website, and you're free to go look at it. There's lots of information on there. ICOS is the International Cardio-Oncology Society that's run out of the U.S., and as I mentioned, the ACC now has a cardio-oncology section, and you can go onto their website and see what the opportunities and education that they have there too. So there's a growing body of interest in organizations and literature. There's also a lot of guidelines and position statements that have come out in the last year or two. So in Canada, we put together a guideline sponsored by the Canadian Cardiovascular Society. ASCO recently put out a survivorship guideline. The European Society of Cardiology has a huge position statement, and they actually have a downloadable app. And ESMO, which is Medical Oncology Society, is also going to be updating their guidelines. So you can see, just in the last year or two, there's been a huge amount of interest generated in this field. What about research? I'll just say a couple words about this. If you go onto the clinicaltrial.gov website, there's close to 200 clinical trials that are registered looking at the diagnosis and treatment of cardiotoxicity. What areas are there that they're looking at? And this is just sort of my viewpoint, and it's not an all-exhaustive list, but I think there are a number of issues that we need to deal with moving forward. Now that we've identified that this is an issue, we need to get better at predicting the risk of cardiotoxicity. So up to now, it's been a very reactive approach. So I see a patient, they're on trastuzumab, I order an echo, I wait till their LVEF drops, and then when it drops, I consult cardiology. That's great. So then they say, okay, maybe if we hold it, we can do this and that. But how can we predict up front who's going to experience a drop or get into trouble? And then if they do, if we can predict that high-risk population, can we give them something up front? So as you know, there have been a number of studies published. There was just one at the ACC meeting recently looking at primary prevention. There's PRADA, was a US study, and Manticore, a Canadian study looking at beta blockers and ACE inhibitors in patients up front. So the whole idea of primary prevention, my only critique about those studies is they took all comers. They didn't take a high-risk population. So how do we predict risk? And once we know risk, high risk, maybe look at primary prevention. What is the best way to image these individuals? And this is a really open question. So, some places are still using MUGAs. There's echo with strain, there's cardiac MRI, and that's a whole talk in itself. But what is the optimal cardiac monitoring in a given oncology patient, and when should it be used? Biomarkers, information out there on biomarkers, on troponin and BMP. When should we be doing that? And what do we do with that information? And I think the other thing is cardioprotection during cancer treatment. That's another one. So there's primary prevention. There's also looking at what happens to people who experience cardiotoxicity. And then finally, how do we get more information about what's happening to our patients? We all understand that in clinical trials we see they report risk of cardiotoxicity, but in the real population, our patients are older. They have more underlying cardiovascular risks. So what's happening to them? And right now, we're trying to establish a cardio-oncology registry, hopefully in the near future. So if you're trying to establish a cardio-oncology clinic, how do you do that? It's a little, and I get asked that question all the time. So this is just one of my fellows wrote this a few years ago, just looking at some basic pointers like logistics. Where is it located? Is it close physically to a place where you can interact between oncologists and oncologists? What about space? Do you have access to imaging? Do you have support in terms of dollars for imaging? Do you have the expertise in terms of cardiologists with imaging experience and knowledge of cancer therapies? And what about support from other healthcare providers? I can't overstress the importance of working with pharmacy and nursing and collaboration, consistent communication between healthcare providers, all very important. What are some of the obstacles? Lack of institutional support. And I say that only from the perspective that this whole field is new. So when we went to our institution back in 2008, they said, you want to do what and why? And so it was really hard for them to get their head around understanding why this would be an important initiative. Lack of academic and administrative mentorship. Because of the novelty of the field, I think this is gradually improving. We are now getting more and more evidence-based standards and guidelines saying this is what we should do, but back 5-6 years ago, those didn't exist. Lack of opportunities for education and training. Again, this is starting to improve. And limited awareness among oncology and cardiology specialists about the need for cardio-oncology services. With the ACC doing what they've done and other groups, this has clearly improved dramatically over the last 5 years. So what about the benefits of a cardio-oncology clinic? Well, these are my viewpoints. I think the benefits would be completion of cancer therapy, particularly for those patients who are being treated curatively, improved cancer outcomes, improved cardiovascular outcomes, and prevention of long-term cardiovascular sequelae of cancer therapies. So that's my list of the benefits. The problem is that we do not have a lot of supporting data to prove that. And so as we're establishing our clinics, I think it's always important in the back of our mind to say what kind of information can we collect to show some of those benefits. And so this is just a few examples of where we have published our clinical experience. And I think moving forward, it will be important as you're setting up your clinic to think about endpoints that you can collect to at least demonstrate what is happening to your patients and are they actually are you showing that there's an improvement in patient care? So what are the challenges moving forward? And I've alluded to some of these already. I think early identification of cardiac risk is probably going to be a combination of cardiac imaging and biomarkers. The question will be, what is the best imaging and biomarkers? How do we prevent cardiotoxicity? So primary prevention and secondary prevention. Optimal cardiovascular drugs to manage cardiotoxicity. There have been few studies done looking specifically at these drugs in the oncology population. And surveillance and monitoring. So what imaging, how often, and for how long? And this becomes an issue not only just in those patients who are receiving curative therapy, So again, I'll go back to the trastuzumab story. 1 year of trastuzumab, they say you're to do imaging every 3 months while they're on their trastuzumab therapy. But what about the patient with metastatic breast cancer who's on pertuzumab and trastuzumab for a year, and then they go to TDM1, another drug for a year, and so on and so forth. So they have sequential HER2-targeted therapies. Do you ever monitor them? Do they ever need to be monitored? Do you just monitor them when they're symptomatic and already in heart failure? That's a very open question for which there is absolutely no data and no recommendations. So where there's challenges, there's opportunities, and this is a quote from Anna Barak, a cardiologist in Washington. Active participation in growing oncology networks may provide critical clues on potential for solutions for these challenges and open horizons for growth. So back to how do we provide the best cancer care and optimize cardiac health? It's by developing these cardio-oncology partnerships. And while that might sound fairly straightforward and intuitive, I can tell you that when I started out in 2008, there was a lot of pushback and a lot of resistance to this, because from the oncologist perspective, they say, well, you know, we don't cause any cardiovascular problems, like we don't do that. And from the cardiologist perspective, they said, well, you know, it's a cancer patient. What does it matter, right? So that partnership piece has taken a few years to establish. The good news is these are all the international organizations that now are endorsed the whole idea of partnering in cardio-oncology. So you'll see up there ACC, ASCO, not just cardiology organizations, but oncology organizations as well around the world. So back to the case, what happened to this patient who had that low LVF of 40%. So she went to see cardiology, and they put her on all these great medications. Her EF improved, and she was treated with, in this case, a non-anthracycline-containing chemotherapy, which fortunately we have choices, and trastuzumab, with no cardiovascular complications, and she was able to finish her therapy. So that's a good news story. So how, I was asked to comment briefly on the practical management of cancer therapy-related cardiac dysfunction, and I'll have to say there's not a lot of information in the literature on this. You can't read this, because I know it's tiny, but I'll just refer you to these quite well, the ACC and AHA heart failure guidelines. These were the ones from a few years ago. And essentially, at least what we know is that if you're exposed to any cardiotoxin, you're already you're considered stage A. If, as this patient did, had an asymptomatic drop in her LVF below normal, that's stage B. And stage B, you actually do have guidelines from this association as to how to manage that patient. So there is some sense of, how do we manage these patients? You can get information from this. However, recognizing this is just heart failure, right? So it doesn't speak to other things like hypertension with TKIs and so on. This was an article published a few years ago, just a broad overview of cardiovascular complications of cancer therapy. And it just shows you there have been some studies looking at the role of ACE inhibitors and beta blockers specifically in cancer patients, but these studies are all very small. So numbers of patients are small, but essentially these few studies show there definitely is benefit to improvement in cardiovascular outcomes with these medications. And finally, I just want to say that we are currently having document the paper manuscript that we're submitting that hopefully will address some of the issues around practical management strategies, not just for heart failure, and that by far has been the most common one, but hypertension from TKIs and arrhythmias and so on. So here are just sort of an example of some of the statements that will be coming out of this paper. So patients with an abnormal LVEF, medical therapy with an ACE inhibitor or ARB and beta blockers recommended prior to potential cardiotoxic treatment, which is sort of the case I showed you, very similar to the case. In patients who developed LV dysfunction or heart failure due to trastuzumab or any HER2-targeted therapy or anthracyclines, cardiovascular care, including medical treatment with an ACE inhibitor, ARB, or beta blocker, and regular cardiology review should be continued indefinitely, even with improvement in LVEF. Patients on tyrosine kinase inhibitors, such as sunitinib, with signs and symptoms of heart failure, optimize their blood pressure, and assess their LVF and cardiac biomarkers should be considered. And then finally, we didn't have a lot of time to speak about radiation, but that still remains a concern. Although with modern techniques, radiation, left-sided chest wall or breast radiation is less of a concern than it used to be. But for patients with a history of chest radiation, evaluation for coronary artery disease and ischemia and valvular heart disease is recommended, even if patients are asymptomatic. So we forget about that. We sort of, radiate them and off they go, and we forget that they are susceptible to experiencing these things 5 and 10 years down the road. So my take-home messages are pretty all-encompassing, but I clearly think that improvement in cancer therapies has resulted in long-term survivors who are at risk of cardiotoxicity, both during their treatment but also long-term. Individuals with heart disease may develop cancer, and as oncologists, we forget about that. That's not just what we do to patients, but now we're seeing patients come to us who already have clearly established heart disease, and if they then get cancer and require potentially cardiotoxic cancer therapy, how do you manage those patients? Close collaboration among healthcare providers is truly needed in order to provide the best cancer care while optimizing cardiovascular health, and that really is going to take open communication. And I think establishment of cardio-oncology clinics and programs really does provide the framework for optimizing clinical care delivery, but it also provides the framework for education and, most importantly, research in this area. This is an international survey, so I put up here. So for those of you who are willing to do this, it's still actively open. My idea behind doing this survey was really to try and identify people's knowledge of cardio-oncology and to identify the knowledge gaps. And so we actually have already participants from around the world, including China, India, South America. And hopefully I'll be presenting the results of this survey at an international meeting down the road. And it also helps us to try and understand what educational needs are for people. And finally, I want to invite everyone to the Global Cardio-Oncology Summit in 2018. It's very close. Tampa is hosting it this year. The Global Cardio-Oncology Summit really came out of us coming together as a group internationally. This will be the fourth summit. The last year we were in London, England. And it really does bring together all of the people interested in this area. It's usually a great 2-day meeting. And if you go to the website, the information about the meeting and the agenda and registration is listed on that website. And with that, I will end and answer any questions. Thank you.
Thank you, Dr. Dent. It was a wonderful talk and overall overview of the task in front of us. I want to make all of you aware that also on the table outside is this flowgram. This flowgram describes our first effort here at the Florida Hospital to provide multidisciplinary comprehensive care to cancer patients. We have targeted breast cancer patients as our initial effort because breast cancer is the #1 cancer of women in the United States, and the #1 cause of death of women who survive breast cancer is heart disease. So this pathway is actually supported with a grant that was graciously given to us by the Hearst Foundation so that we can offer these cancer patients who are undergoing therapy with either anthracycline or trastuzumab 3D echocardiograms with strain imaging. Strain has the ability to perhaps predict those patients who will then subsequently go on to have LV dysfunction. And it is supported by a nurse navigator to help our patients schedule and also help the medical oncology team get these reports timely. And if the patient is suffering any evidence of subclinical or clinical left ventricular dysfunction, then there are 3 cardiologists that are committed to seeing these patients expeditedly, and those are Dr. Carol Ma, Dr. Thomas Walsh, and myself. And we do invite the other cardiologists in the division, if they want to partake of this effort, to contact me, and we'll make sure that you get to be a part of the team. So as I've given you a few minutes to ask about questions, Any questions for Dr. Dent?
Can I make a comment? So just a comment about when we established our clinic. I've seen and talked to a number of my cardiology colleagues around the U.S., and sometimes I see it's one person in a center, and they are the cardio-oncologist sort of clinic, and they run the clinic, and that's extremely hard to do. How we set up our clinic is we have 4 cardiologists. The clinic always remains the same time. It's a half day. Those cardiologists rotate through, so they share that clinic. And I think it's very important not to rely on that one person who's your cardio-oncologist, but rather to rotate cardiologists through, because people are away, they're on holidays, and then you're stuck if you have an urgent case to refer. So if you can get a group and rotate them through that clinic, I think that's ideal. We also did, I love the map. We did, I didn't show it to you, we did develop a referral sheet, which also serves to ask why they're being referred, but also tries to highlight, is it urgent, elective, so less than a week, 1 to 2 weeks, or 4 weeks, to give the cardiologist an idea of how urgent the question is or the need is. Happy to answer questions. Yes?
Wonderful talk. I'm going to go to the part you didn't discuss very much, which is the radiation.
Yes, I know.
Cardiac surgical world. These are really challenging patients. And the guidelines say see them every 5 years, et cetera. Is there any data to suggest if there is preventive ability in terms of these are statins or anything else with coronary disease, with the valvular components, and you didn't talk about the actual myocardial fibrosis, chest
Right,
wall
right.
changes that occur that create all sorts of problems.
I think that there's clearly data in supportive of statins, but that is more looking at the acute management of these patients. And the problem is that I agree radiation is an issue, but I think it's an unrecognized issue. So these patients, after they finish their radiation, they are not, as far as I'm aware, usually in an established surveillance program where they're undergoing any imaging, where they're looking at coronary calcium, for instance, and so on. And so ideally, at least if they're being monitored for blood pressure and other things, that they should be on that. But there's really little data on that I'm aware of, looking at the potential, treating or giving them therapy, primary prophylaxis up front to prevent the long-term radiation consequences.
I can make an additional comment. About 2 years ago, there was a statement from the American College of Cardiology, unfortunately not addressing what we'd really like, which is how can we prevent people who need to have radiation as part of the therapy. So there was a statement approximately 2.5 years ago from the American College of Cardiology referencing patients who had received radiation therapy to the chest. So unfortunately, there's a paucity of data of any type of intervention that we could provide ahead of time to prevent the radiation-induced heart disease. But there were guidelines that said even in the asymptomatic patient, at 5 years post-radiation, we should do stress testing. And almost,
imaging. Yeah, I agree.
and almost every 2 to 3 years afterwards, even if they're asymptomatic.
Right, so I think there is data to support that. The question is what to do with that information, and then you're waiting. Essentially, it's a reactive approach, right? So you're imaging, and then you wait until you see something, and then you treat that. I think, and even that recommendation, I don't think that's actually being carried out very commonly at all in terms of what happens to these patients.
I agree with you. I think there's a lack of actually
Because they
recognition
go
of
back
that.
to their primary care provider, right? At least in Canada they do. And the primary care providers aren't aware of these recommendations.
It seemed like that was a gap in your program, that you weren't capturing the radiation patients to actually follow them up. It seemed like there was a focus on an awful lot of agents and not radiation, yet essentially the time that somewhere 10 to 20 years, depending on the era, you're going to see the effective
Yeah. So then I would say that in that survivorship piece, that really then becomes the survivorship piece, right? So we have that clinic, and the cardiologist in that clinic that's a perfect, area for her to undertake. And to not just her, but that cardiologist, but to help educate primary care providers, because realistically, we can't see all of these patients. But what we can do is give guidance to primary care providers to help with that. But yes, I agree. There's definitely an unmet need there. And lots of opportunity for research as well and how to do a better job.
Dr. Sylvester, thank you.
Thank you for your talk. It sounds like it's a research opportunity because a lot of the thoracic imaging will collect
Calcium.
of the chest and calcium scores.
Yep.
So there's an area for longitudinal collection of the progression of calcium in the coronary arteries and maybe an opportunity just at the same time as imaging for the malignancy. I have a different question, and so my question is, we see a lot of patients with heart failure in transplant after, so the heart is burned out, and it's not only when the patient is seeing the HER2 is inhibited and come back. But so what we wrestle with is, when is it a cure? And how far, because our thoughts in transplant, especially with breast cancer, are it's never really a cure. We empirically say 5 years, but we can't transplant all of these patients. LVADs are good for the left side, but these patients get 5 years of function. So when are they cured, and when is what's the real risk with transplantation or other therapy?
So, in breast cancer, that is a very difficult question. When are they cured? Because I have seen women come back with recurrences 15 years, 20 years. Not commonly, but, everyone uses that 5-year mark in cancer therapy. Certainly for GI malignancies, most people are cured, but 5 years in the breast cancer diagnosis doesn't necessarily mean you're cured. The recurrences tend to occur, the highest risk is in the first 2 years, after which the recurrence rate goes down, but it still never goes to 0. However, if you see someone out at 10 years and they need a transplant and they've had been treated curatively for breast cancer, then, I think that would be reasonable. The problem is there's no guarantees. They could have a recurrence, 5 years down the road. So it's the balance, right? I think that really requires a conversation between the oncologist and the cardiologist on an individual basis, because breast cancer is really tough. It's really hard to say you're cured for your whole life. If you do a transplant and then you say, well, they get another 10 years, is that reasonable? I mean, and so then the question is, if there's a short list and they may potentially have another 10 years after transplant, is that reasonable, right? So it's really hard to make hard cut lines for breast cancer. But I usually say, at least you're out a few years. The same thing holds true. I've had that asked of me for kidney transplants too. Now, not quite the same because kidneys are easier to get, but the same thing. They want usually 2 years, at least 2 years out from their breast cancer diagnosis. But again, no guarantees that it's not going to come back.
Dr. Alamani?
To add to your comments, I think that it depends on the type of breast cancer too, because some breast
Dr.
cancers you were
Alamani,
mentioning tend to
breast
recur
cancer.
much later, 10, 15 years later. For example, ER-positive tumors, but if they are negative tumors or HER2 amplified, they have not recurred in the first 5 years, then the chances are much lower that they're going to recur. So it depends on the type of cancer. Depends on the stage.
Yeah, I mean, of course, if you have a woman with a locally advanced stage 3 breast cancer, much higher risk than a stage 1 ER-positive breast cancer or triple negative breast cancer, so you do have to take that into account. Having said that, I've also seen women with triple negative breast cancer who get out to 6, 7 years, and there's some data to show that if they make it that far, they have the same prognosis as an ER-positive breast cancer. So that's why I think it's hard. It's the receptors, it's the stage, how old are they, what is the rest of them like? I find those almost have to be a conversation type on an individual basis. Yes.
Dr. Akala first, then Dr.
Hey, yeah, question, thank you for joining us and visiting us today. We oftentimes will see patients from a cardiac surgical standpoint that have ongoing requirements of chemotherapy, and they might have had an underlying cardiac problem before and require now cardiac surgery during their chemotherapeutic source or their course. In your map, what type of consultative services do you provide in support of those patients? Because oftentimes, they have pneumologic problems from platelets, or they have a coagulopathy, or even immunosuppressive circumstances.
Right.
How do you put your arms around those?
So that's really challenging because, as you know, many of our patients clot. So they're often on anticoagulation. So our cardiologists,
Like clotting, we
They don't like bleeding. They don't like bleeding.
they don't like bleeding. And the problem is all our, particularly with the metastatic population, they tend to clot and they're on, so it's hard. It's that balance between clotting and bleeding. But so our cardiologists that work in the cardio-oncology clinic do work closely with the cardiovascular surgeons. And so there is that, open communication as well. So clearly they have to work together. So I didn't put that piece in. I put more of the medical piece in. But yes, it does get quite complicated. So holding the cancer therapy, determining the coagulation status. We also have a thrombosis service that we work with, so they come in on that as well. So specifically trying to manage the anticoagulation during any surgical procedure for these patients. So that's part of it. It's probably not the biggest piece of what we see, but it does happen, absolutely. Yes, yes, yes. And again, when those complex cases come up, we would probably discuss them at our multidisciplinary rounds, which we invite everyone to join, including the nurses and fellows. And those are real, eye-openers for us, because we, sometimes the cardiologist will say, oh, that's not a problem. You can just go ahead with your chemo and we'll take care of that. And we're just freaking out. So I have a patient right now with this big myxoma, and who's getting on cancer therapy, and we're watching it, and she's doing okay, but, as an oncologist, that just makes me very nervous, and they're saying, okay, no, we'll take care of this, and you do your cancer therapy. So it really is that understanding each other and having a comfort in sort of working together. But it has, clearly, there's been cases where I think as oncologists, we have said, no, we can't do that. And the cardiologist said, yeah, you can. We can manage that. So it's that balance. And it really often comes down to the individual patients, because these patients are becoming so complex with not just their cancer therapy, their underlying risk factors, then the consequences of the cancer therapy, and so on. They're really, really complex, and sometimes actually very, very sick, as you know. So it really requires a conversation among multiple disciplines.
Okay, 2 last questions. Oh,
We have actually worked with your team on the cardiovascular alumni program. Are some of your patients from this program also program members in your CD alumni program?
Not that I'm aware. What I can tell you, what we've done though, is so all those patients. I showed you some data. As you start up your clinics, we have a database. So every single patient that's been referred to our clinic is collected. The information is collected in our database, all the way from why they were referred, their underlying malignancy stage, treatments, and so on. And as much as possible, we've collected all the cardiovascular risk factors as well as their clinical outcomes. So we continue to follow them as long as possible. And then once they're referred to the Survivorship clinic, we link that data. So they continue to be followed there, and that data and follow-up data is linked, so that we can try to at least eventually get some long-term data as to how these patients do.
okay, 2 last questions, because I think we're detaining Dr. Dent, Dr. Taylor, and then Dr. Rothbard.
Going back to the radiation question.
Yes.
I'm wondering, is there any data or recommendations you can screen for prevention of recurrent cardiac disease associated with radiation? I often see patients presenting with heart failure or pulmonary hypertension, and it turns out that that's strictly physiology. So how do we look at that going forward?
Not beyond what I think is recently coming out. They're saying, at 5 years screen, at 10 years screen, even if they're asymptomatic. I don't know if anything beyond that. And I would argue that that's something that's just coming to the forefront. I don't really think that's being done on a routine basis. So I think the whole radiation piece is lagged a little bit behind in terms of people have focused more on the consequences of the chemotherapy drugs and the targeted drugs. The radiation piece really we need to improve upon that. Because yes, I know it's not just it's the pericardium, it's the valves, it's the coronary arteries. Radiation can do a lot of damage. Aorta. And again, as oncologists, we never see that because we discharge them. But I think that piece is an area that really needs to improve. And there's been less focus on that. And to be honest with you, I think part of the reason is we need to engage more radiation oncologists in the field of cardio-oncology. There was an obvious reason why, as a medical oncologist, we're involved. But I think that would also help push the field forward as if we had more radiation oncologists involved.
Dr. Rockford.
Excellent talk, thank you. Timely. Related to Akla's question, from the interventional standpoint, thrombocytopenic patients on treatment that we've got to put on dual antiplatelet therapy, or patients with atrial fib needing, or cancer patients need a intervention, so you've got someone on a anticoagulation. Is there, I know there's a monograph out, but short of that, do you have general guidelines for the platelet count that is safe, and do you alter the dual antiplatelet therapy such as stop and
Wow.
maintain?
That's a hard one.
That's a hard one. So I mean, I know that, stents go in, drug-eluting stents. I'm learning a lot as an oncologist about all these things that happen to patients. And then they have clots, and then they go on thinners. So, from an oncologist perspective, we're always looking at the platelet count in terms of delivery of the cancer therapy. Fortunately, for a lot of the targeted agents, they don't impact the platelet count, but certainly the traditional, chemotherapy drugs do. And so generally, we like to see the platelet count 75,000 or higher. We work closely with our thrombosis team as well, and quite honestly, a lot of our patients end up being on low molecular weight heparin and not the DOACs, because of, if there's concern about bleeding, obviously you want them on something shorter acting or something where you can control the dose. In terms of the impact, on the drug-eluting stents and how we manage that, I really do lean on my thrombosis colleagues to help me through that. The good thing is, though, is that a lot of the new therapies don't. We can get away with a lower platelet count, though. We don't really need to have that high platelet count. It's really just if you're giving anthracyclines and some of the traditional chemo. And even then, we can modify the dose.
Dr. Dent, thank you so much.
Thanks.